because I love chemical weapons, and
you love
that's going to be taken
weapons.
out of context.
Hey guys, welcome back to Curbside to Bedside. It's Ron and Floyd. We're joined with a special guest, Chip Lang. Chip, can you provide a little bit of an introduction?
Sure. So I'm Chip. I'm one of the... I started to do the introduction that I do when I'm talking to a patient. How great is that?
That has some Pavlovian response really ingrained in you there.
Chip, who exactly are you?
Who is this masked man?
So I'm Chip. I'm an emergency medicine PA that practices in rural Missouri. I've got my own blog and podcast called Total EM, where I put a bunch of different stuff out. I do a weekly podcast with all sorts of goodness in there, then sprinkle some other stuff on top. Really love emergency medicine and critical care type situations. Also, I love ultrasound. That's like my other big thing that I like to do. And so I just enjoy teaching, and I see your guys' stuff. You've been doing some great stuff. And one of my favorite things that you guys have been talking about that I love to talk about too is all this bullshit about fentanyl. Like, fentanyl is a real problem, but there's some bullshit sprinkled in with it. So I'm sorry, I'm kind of stealing over for a second.
Would you say it's adulterated?
It is adulterated.
Well, that's okay, because that's what we're going to talk about today.
Oh, well, that's perfect.
Yeah, I think we first met at the ultrasound podcast in Lexington. Was it last year or the year before?
Ultrasound podcast?
About last year.
Or the
Podcasting course.
The podcasting course. Since then, you've been pumping out like a podcast every week, and it sounds like, it would take me a month or two to actually prep for that quality of a podcast, and you manage to do it every week, so I'm quite impressed.
I don't know what kind of drugs you're doing, Chip, but it's certainly not fentanyl.
No, it's not fentanyl. That would slow me down too much.
So you did a podcast on PPE in opiate overdoses, and that's kind of why we wanted to get you on the show. Just anecdotally in our area, this has become a thing. Where there's been a lot of reports of first responders getting exposed to fentanyl or fentanyl analogs and then becoming somewhat symptomatic and requiring naloxone. And some people are actually carrying personal naloxone, and there's even a Jim's post where Jim's actually shared some medical gloves from a manufacturer that are designed to be, quote, resistant to fentanyl.
And did you see I decided to blow that up too? Because I was tired of that shit. And coming straight from like Jim's really, really pissed me off on that one. Yeah, I mean, every now and then they come up with a really good article. It's just about 3 years after everyone else has already talked about it, I think is kind of the main thing there. So, and a lot of times they get bastardized to the point I don't think it's as good a material. So, but it's really bad when you're sponsored and next thing you know, you're trying to, sell shit that doesn't actually need to be sold. And I think that's the thing that killed me with the nitrile gloves, is because they make it sound like they're these super duper gloves. Nothing will go bad if you use these, but if you use anything else, you will die. I think is kind of the way they pitch that. For
as bad as Jim's is, the hazmat community is even worse, because they sell all sorts of decontaminating solutions and special suits and monitoring equipment and all this shit that you will never ever need. And I look at that and I go, decontaminating solutions? You mean soap and water? And it's like $300 a pail for this shit. It's like, it's developed by the Navy. Oh, that's great. They've had soap for hundreds of years too. So it's not like any of this is revolutionary.
Now, are you guys in your area bad enough yet that you're wearing actual like chem suits? Not you guys particularly, because I think you're smart enough not to need that. But like anyone getting that crazy yet where they're busting out the hazmat suits because there's a fentanyl overdose?
Not that I know of. And we work for an agency that carries SCBAs on our ambulances. And I would probably ruthlessly make fun of someone if they actually did, barring it was a clandestine lab that was confirmed. That would be my only exception to that.
So we've actually had a few cases in surrounding areas of where we work of people being exposed to what was reported to be a white substance, presumably fentanyl or one of its analogs. And I think that these people genuinely thought that they were exposed, but I don't think that their symptoms were consistent with an opioid toxidrome. And to my knowledge, none of these cases have been confirmed exposures.
And I bet you most likely, because I've seen this situation play out several times in my area, and it's not actually our hospital staff, it's usually the local sheriff's department, police department, whatever. I have not seen anyone pre-hospital in my area because I think I've preached it hard enough to our local people. They're not doing it. And usually when they're bringing in law enforcement by EMS, they roll their eyes very, very hard as they're walking past us, like mouthing, "I'm sorry," as they're walking by to the room. Yeah, it can be that big of a problem sometimes. But basically, what's going on there is most likely is the same thing that probably happened in your case when you're talking about someone saw this powder, they treat it like an opiate overdose, and guess what? Because they read so much shit about how they're going to die from being exposed to fentanyl, even though they're probably exposed to this shit multiple times before, the mind's a powerful thing and can really screw with you in so many ways. And so next thing you know, you start getting lightheaded and maybe a little nauseated because you're freaking out. And because you're freaking out, I'm freaking out. And so I'm going to start feeling that way. And next thing you know, it's a chain reaction. Now you got like 4 or 5 different people who honestly believe that they're having a reaction.
And there's actually a name for that, right?
Right. And the name escapes me right now. Sorry.
Yeah, me too.
I just called a psychogenic MCI.
And
you're all black tags. Let's go.
There's been tons of media reports lately, but it seems like they've just emerged within the past year or so. But we've been treating this stuff for quite a long time. Are there any cases that you're aware of someone getting exposed to fentanyl or an analog that has actually been confirmed by toxicology studies?
As far as actually confirmed, no. I mean, like you said, we're seeing this in the media where, X officer was exposed to fentanyl, had to receive multiple doses of naloxone, but they were never apneic or never had decreased respiratory rates or anything like that. But simply someone who is the same scenario that we're talking about. They may have been a little bit lightheaded. Maybe they passed out for a second. Maybe. But next thing you know, they're getting a shit ton of Narcan because that is what they believe is what's going on, and not the actual indications for naloxone administration for an emergency setting. So those types of things, I haven't seen anything yet that's actually been confirmed via a toxicology source, and especially nothing that's come out specifically in the toxicology literature. If anything, it's quite the opposite.
What is the potential for us to get or to become symptomatic after an exposure like that?
Great. So it depends on the route. Let's start with the easiest one, which is the most common one, which is actually the hardest to have any response to, and that's absorption through your skin. Now, everyone wants to jump to fentanyl patches because, well, if there's a fentanyl patch, then it has to be easy to absorb through the skin. And I call a big old bullshit on that. It took decades for them to figure out how to create fentanyl in a way that can be absorbed through skin. Because fentanyl, when it's in its powdered form, basically, our skin, if it's doing its job, which it basically is, otherwise you're probably dead, is meant to be this very strong barrier against the outside world. So the patches are unique because it takes even time for it to work. Like usually peak effect is around 35 hours. And if you have been exposed to something for 35 hours, you're probably an idiot to start with. But I really doubt that that's your issue there. So for a powdered form, it's going to take a very, very long time and a very, very high amount over a large area of your body. So just touching it with your hands, it's going to take a long time. All you have to do is wash your hands off, sometime in the next couple hours, and you're probably going to be safe. And then the other thing is too, this goes back to if you're worried about that type of PPE, wear freaking gloves. And it's EMS and emergency medicine and stuff like that. You should be wearing gloves anyway. I mean, that's something that we get taught on basically day one, BSI scene safety. I mean, how freaking hard is that concept? Or did I say BSI scene safety?
Yeah.
So,
I mean, it works. It's
again, it was ingrained in my head. So, everyone who's ever done the EMS training knows how that goes. But yeah, I mean, for as far as the skin absorption stuff, it's incredibly hard to do. It takes a long time. And really, again, simple measures help reduce this risk. So as far as the skin goes, I find it very unlikely. Now, there are a couple of ways otherwise that you can have some issues with it, if you want me to go into that right now. So the first one, or the other ones, are absorption through your mucous membranes, which actually takes quite a bit of time as well, just because there was one case with a veterinarian that which is included in the show notes I had, and basically he got probably about 1.5 milligrams of carfentanil, and then xylazine, I believe it was 50 milligrams.
It was elephant Versed, basically.
Yeah, exactly. So he got it into his eyes and mouth. It was more like a splash type injury. He cleaned it out, but he got drowsy after a couple of minutes and responded promptly to naltrexone. Now, did the guy probably need it? Probably not, but I understand giving it in that case because he got a shit ton of exposure and not knowing what's going to happen there. Understandable. But there's about a 30-fold increase in absorption from the mucous membranes versus just direct skin contact. So as long as you're wearing some sort of splash protection, which given in most of these cases, we're not going to run into a liquid substance anyway. It may be a powder, and the powder hopefully is not aerosolized, because if it was aerosolized, say like a big old drug raid that for some reason you as EMS or we'll talk about law enforcement as well, but I mean, if maybe you threw a shit ton of flashbangs and now there's like you said, there's this clandestine lab where there is just aerosolized fentanyl everywhere, then yeah, you may need some substantial respiratory protection, because I'd be more worried not about the skin, not about the mucous membranes, but about the actual inhalation exposure, because that's where people can actually get harmed. But in most cases, if you're really worried about it and it's not a high risk situation, just a simple N95 mask would work well. And the reason why toxicologists recommend the N95 mask is because of the better fit than just the regular mask that you can use in like the hospital setting or stuff like that. That's really the only reason why they suggest the N95 is just for the better fit for it. But again, all these situations, I mean, it's low risk as long as you're doing simple PPE measures.
The one of the things I want to talk about on the aerosolization standpoint was the Dubrovka theater incident in Moscow.
Yeah.
Mostly because I love chemical weapons, and
you love
that's going to be taken out of context. Save
that soundbite for later. And he never flew on an airplane again.
I always get frisked for some reason. I don't know why. Like more than usual. I get the special pass. But for those who are,
do they make you take your pants off?
Yeah, I mean, I don't know if it was sanctioned or not.
Yes.
His uniform was like real weird looking. I don't even know if he actually worked there or not, but he looked if he had a gun. So anyway. So there was these nice little Chechen rebels that took a whole bunch of people hostage in the Dubrovka theater in Moscow in late 2002. And essentially they got into a standoff with these guys, and the Russian Spetsnaz, which is their military special forces, eventually elected to pump a, quote, sedative gas into the theater for around 15 minutes, if I'm recalling this correctly. And what ended up happening was they killed quite a few people. And it actually wasn't from the military offensive. It was actually from... There's debate as to what agent was used, but they most likely think it was a combination of halothane and aerosolized carfentanil. And there was some confusion in the initial management because of like the meiosis and stuff like that, where these some of these casualties were getting atropinized at arrival at the ER because they thought a nerve agent had been used. But then when they tried naloxone, they started having good results. And they weren't using a whole lot either. let's see if I can find from the study here, one of the excerpts. A fentanyl derivative was used to neutralize the terrorists, according to a Russian health minister. Despite the claim, 16% of the 800 hostages in the theater died, so that's 127 out of 800, and more than 650 of the survivors required hospitalization. The Russian health minister attributed the deaths of the hostages to their poor condition from limited food and water and immobility during the 3 days of captivity. By 12 days after the rescue, 67 hostages and 9 rescuers remained hospitalized, 5 in critical condition. So even from this study that's often cited as the power of aerosolized carfentanil, yeah, there's some definite confounding factors in there because these people have been held hostage for 3 days. So I never really
like in Soviet Russia, it's not carfentanil or ramifentanil kills you; it's starvation.
They ran out of potatoes again and vodka.
Damn it!
I hate it when that happens. But going off on one of my tangents. It's extremely powerful when it's weaponized, which is essentially was. But if you, and Chip, please feel free to correct my paramedic level understanding of pharmacology, but the lipid solubility of carfentanil is ridiculous. And that leads to some very wild absorption and distribution when it's actually absorbed systemically. So they actually go into some of the autonomous redosing or reanalgesing due to theorized, like if you have someone with a lot of adipose tissue or something like that, it could chill out there for a while until it's actually mobilized from those tissue stores. But
we see that a lot with some really potent opiates, I think is the one thing to mention. It's not just carfentanil. We see this with other stuff too. I believe Demerol used to have a reputation for that as well, because that caused a lot of issues down the line. But yeah, absolutely.
Ryan is a huge tox nerd, and
I like how it's like my little basic understand. Like, yeah, sure. No,
I really have no idea what I'm talking about. I just listen to smart people and parrot what they say. It's actually my key to success.
Well, as long as you're picking the smart people, you'll be okay.
He'll be very quick to correct someone who uses the words opioid and opiate interchangeably.
Well, or at least you're not saying, because this one drives me nuts, narcotics and opiates being used interchangeably, because those actually have 2 very different definitions with it.
Yes.
And by the way, I hear a baby running above me, so if you hear that thunderous sound, it's not thunder yet. It's just my children.
Let's see. Unpredictable intake of opioid. Yeah. Okay. Floyd's comment sent me off. Unpredictable uptake of opioids after given a dose is a problem. Up to 5-fold variation in plasma concentration may occur after the administration of a standard dose. In addition, there may be a 3 to 5-fold variability in the therapeutic plasma level of opioids needed to effectively block a defined response. So that's controlled. That's not the rap. And that's kind of the feature of this. Like, all of this was pure. All the stuff we're seeing on the street, we don't know how much of it is actually fentanyl, how much of it is adulterated with, I don't know, like meth or alprazolam or some other medication that is probably not what we think it is. So this is a case study from basically a perfect world where they knew, well, the Russian government doesn't really admit it, but there's a fair amount of international, scrupulation that's gone in and figured it out. But they've been like, hey, this is pure carfentanil, and
ramifentanil was in it too.
Yeah,
if I remember right. They tested for positive for both, wasn't it?
Yeah, it was kind of a mix. I think the majority split was towards carfentanil. There was some halothane in there too, I believe. But what confounded that was one of the urine samples they drew off one of the survivors had actually been anesthetically managed with halothane during their course of care as well. So they were kind of like, I don't know. But there's been some discussion from the U.S. government about using carfentanil and other sedative agents as like a neutralizing tactic, which goes back probably like to the 80s. We can edit out most of my rambling. I did a lot of that.
Stares longingly into the distance. No, actually, I believe all your stuff is important to apply there, because that was a unique situation, because it's one of the few times where you actually got to aerosolize a shit ton of this and see what happens to a bunch of people. And you're right, there's some debate about what exactly killed a lot of these people, but a lot of these people did test positive for that, and it was tested positive not just in their system, but also on their clothing and everything else. And like you said, urine and blood samples and all that good shit. So, I mean, again, that was a really unique situation because of the fact that it was so aerosolized and so much in a weaponized form. I mean, realistically, when you are walking into the next overdose house, how likely is it that it's going to be aerosolized, and how likely is it that it's going to be an amount that will even make a difference? I think is the big part there.
Right, and I think just routine day-to-day operations. I mean, we don't want to get in the habit of saying, "Oh, this is just another routine call." But when we respond to a presumed overdose, what a lot of this is going to end up doing is just delaying care. Proper ventilation and administration of naloxone. So, and I think that that's going to keep a lot of first responders from wanting to treat these people.
And that's the thing I see when I'm reading through all this stuff about these PPE measures that some people are advocating for, is I'm thinking like, man, even if you have that on your truck, how long is it going to take you to get in a bunny suit? How long is it going to take you to get in some form of a suit that is going to be for all these protections that you're advocating for? Realistically, your person's probably going to die in the time it took, not only for the initial response and call and everything like that to come through, but for you to then get there, wait for law enforcement. If you're in an area that you are waiting for law enforcement to actually clear your scene, and most likely they're not going to want to go in it either, because all their stuff says that it's dangerous as hell. Even though, again, we've got good evidence that says otherwise, but a lot of people freak out about it. So they're going to call the fire department, and the fire department's going to wait. And so next thing you know, like, the guy's dead. So that's the part that I think is whether or not you want to debate the ethics of, is this something that we should be doing, or how we do it, or stuff like that. Like, all that is set aside. Realistically, these patients, you need to be treating them, and you need to be treating them in a very time-sensitive manner. And doing all this other shit is usually totally unnecessary, unless, like you guys said, there's a clandestine lab. There's very specific reasons why you're worried about true exposure directly.
I would like to personally blame the DEA for law enforcement's trepidation towards these scenes, because the DEA statement on opioids are pretty much diametrically opposed to the people that I trust the most, which is the American College of Medical Toxicologists and the American Academy of Clinical Toxicologists, who actually put out a position statement literally entitled "Preventing Occupational Fentanyl and Fentanyl Analog Exposure to Emergency Responders." And they literally just say, "Hey, bros, nitrile gloves, don't be a dumbass, wear an N95 if you want to. Peace." Like, that's it.
Yeah. And I think it's worth noting, too, the fact that, again, it's not just them, it's everyone else that's starting to come out with it, too. And some people who originally were very, very cautious because that was what was being recommended by the DEA have since turned around. Most people are now not doing that. But the problem with things like this is that it develops into dogma really quickly. And I have noticed this, I'm sure you guys are noticing it too, that you probably have some colleagues or maybe some people from other agencies or whatever who are still stuck with the original position, which was freak out, everything's all bad, everything's going to kill you. And so I have colleagues that, I run into, and there's this one person very recently who keeps posting shit about carfentanil and fentanyl. And I keep sending and posting the same stuff. And the reason why I'm posting it every time is because I want to make sure for that one person who isn't getting on very regularly onto this forum is not going to be like, oh shit, like it's ultra potent. Like, all it takes is a few micrograms and it's going to kill me. Like, no, guys, like, just actually read a little bit of toxicological literature. Just because some representative from the DEA told you at a conference a week or two ago that it's all bad, probably really isn't paying attention to everything else, because everyone else is showing other stuff here. And oh, by the way, think about the actual pharmacology of it and how this drug works, and you'll realize really quickly you don't have to freak out about it. But unfortunately, there's so many people out there who stuck with the original dogma that we need to do stuff like this to help with the dogmalysis of it.
And I would like to segue into another point that you already kind of segued into. Is it true that patients experiencing toxicity from the so-called ultra-potent opioids may intrinsically require more naloxone as compared to our traditional opioids, such as black tar heroin, or something that's more along the lines of like an actual naturally occurring opiate?
Is this a loaded question? Why, yes. Yes, this is a loaded question. So no, absolutely. this is something that I'll admit I even fell into this trap early, but given when I reacted to that situation, it was before we had really good evidence on how this was working. And I was working off of evidence that we had at the time, which is really all medicine is there are a lot of things that we're practicing. There's practice stuff we're all probably practicing right now that another 5 to 10 years are going to realize it's probably not the best method. I mean, look at sepsis management. How much has that changed in the last 5 years, 10 years, 20 years, So with all that said, I was one of those that early on ran into a carfentanil case, and it later was toxicologically confirmed as that patient died from carfentanil. That was a situation where there was a high clinical suspicion. At the time, it was believed that you need to give higher doses of naloxone, and we did such. And when I'm talking about high doses of naloxone, like we ran out of naloxone in the ED. Now, given I'm in a smaller ED, but we used up all of it, and pharmacy had to bring stuff. And I was like, if we're using this much, we're done. The guy's dead. We're not getting anything back. And we got Rosk back briefly after about 20 milligrams, but I don't believe at that point that was anything related to that. And then when I started doing deeper dives into it, which I think you guys have talked about too, I mean, physiologically, that's not exactly what naloxone's actually doing. And so I admit I made that error, but looking back now, I wouldn't do that again, because the way naloxone works in some of these newer studies with, ultra potent opiates, or however the hell you want to call it, but fentanyl, carfentanil, those types of derivatives, really, when you're giving these medications, you probably only have to give about 2 milligrams in most cases. Maybe, I think you were talking about 8 milligrams was kind of the most in that one case, but that was a little bit different. But like I said, in most cases, I'm probably giving a round or two of naloxone, 2 milligrams. And if that's not enough, then they need to be intubated, and we need to start looking for other causes and treat it no longer just as an overdose. We need to start doing some other things with it too.
So could you elaborate on some of the pharmacokinetic principles of potency versus affinity? Because you mentioned potency, and a lot of people hear, highly potent drug X. Oh my God, we have to be absolutely terrified of it. Is it have any more or less binding affinity for the same receptors in the brain than any other drug? So morphine is typically touted as having a pretty hard time getting across the blood-brain barrier. So it might not have as great affinity for the mu receptors as something like carfentanil or one of your synthetic fentanyl analogs. Now, I kind of just pulled that out of my ass, and someone's probably going to send us a nasty email being like, that paramedic has no idea what he's talking about, which would be true. But my point stands. What can we extol some of the differences between potency and affinity?
Right. So as we all remember from all of our training, because hopefully it was taught somewhere along the line, and we probably forgot it because we slept a long time since then. But there are only so many of every type of receptor that's out there in the body, right? So there's only going to be so many mu opioid receptors, or whatever type of receptor we're going to talk about here. And ultimately what that shakes out for us is what we're talking about is that, you can keep trying, and you can dump a shit ton of morphine or hydromorphone or fentanyl or whatever else you're wanting to use for your opiates. But only so much of it is going to ever cross the blood-brain barrier, or is going to hit the receptors that you need, or stuff like that. So all those types of things, just because I'm using a really, really high dose doesn't necessarily mean that I'm going to bind any more receptors, or at least my ability to actually get onto those receptors, in addition to what lower amounts I was using before, is probably not going to make a huge difference. I'm dumbing it down here, but is that basically what you're fishing for?
One of the things I like to point the listeners to is the, about to butcher this guy's name, the Mellicar et al., which was naloxone displacement at opioid receptor sites measured in vivo in the human brain, where basically they observed that about 13 micrograms a kilogram of naloxone, which works out to about a milligram in an 80 kg dude, was the requirement to produce what they estimated to be a 50% receptor occupation. So 13 mics a kg got about 50% of the mu receptors occupied by the Narcan molecule. And they found that that's pretty consistent with the clinical dose, the step doses that most people recommend, the toxicology literature like that backs up, which was that 0.4 to 1 range for the initial dose.
So I only caught half about about half of that, but yes. but no, what you're talking about is about the fact that naloxone, I mean, realistically, it's going to bind pretty quickly. So even if you're worried about the higher amounts of absorption, I mean, naloxone is going to still bind. It's still going to bind very quickly, and it's going to hit those receptors, especially at the concentrations that you're talking about, which is really low. And like you said, it's about 1 milligram for an 80 kilogram individual, right?
Yes.
Okay. So sorry, I'm rephrasing to make sure I heard all the big bits.
Oh, you're fine.
But yeah, I agree. I mean, you're not having to use much naloxone at all, and I think 2 milligrams in most cases is more than enough.
I think what we're getting at is trying to bust the myth of naloxone resistance, which we want to point out to our listeners just means that particular opioids, such as like fentanyl and carfentanil, are resistant to standard naloxone doses, which means, like, say I give 0.4 of naloxone IV, and then if no response, I escalate the dose and don't see any response to that. I have my own opinion for why this happens, but we hear a lot of anecdotes of patients requiring huge doses of Narcan, and especially in our area, it's not uncommon for 4, 6, or 8 milligrams to be given to a lot of patients. But I think if we look at the case studies that are out there, it's actually pretty rare for patients to not respond to the traditional standard dose of naloxone. And before you came on the show, I think we all discussed a few of those cases. What is your opinion on, like, exactly why would a patient not respond to naloxone? Because if our people are seeing this in the field, is there a good explanation why it's not working?
Yeah, so long story short, at least with the cases that I'm seeing, most of the time, if they've already gotten a couple milligrams of naloxone, we may try it again with a new like patent line, or we may do intranasal, or we may do a different route just to see if that makes a difference. So maybe we'll go up and repeat up to 4 milligrams total, but that's about all that we're doing anymore. And that's just to see if maybe there was some issue with the initial absorption or stuff like that. But long story short, no. I mean, in fact, I had a case not that long ago where a patient was coming in and severe respiratory depression, looked like shit, basically met the LLS criteria. So, looks like shit. It's someone who needs to be taken care of, but they've already received 3 milligrams prior to arrival. Did we give any more naloxone? No, because most likely there's something else going on. And sure enough, there were benzos in his system, and there were a few other, there were like benzos, cannabinoids, all that type of stuff. And even though he doesn't have a history of any benzo prescriptions or stuff, you got to keep in mind that sometimes the benzos get mixed in with whatever's getting cut for, the quote unquote heroin that's usually not straight heroin anymore. In fact, I can't remember the last time there was a true heroin overdose in my area where that was actually toxicologically confirmed as such. There's something else always in it. So, intubate them, secure their airway, do what we need to do, and start doing supportive care, which is exactly what we did with this patient. And if anything, and this is going to be something that to think about for a second, this guy got really hypertensive and tachycardic more and more after each dose of naloxone. And he has a history of chronic opiate use, like he has opioid prescriptions. So, not to turn the tables on you guys, but can you think of why that's going on?
He's either going into an acute withdrawal state, or he's
having acute withdrawal. Exactly. So what did we do? We just made things worse in our situation. And so absolutely no more naloxone for this guy, because his airway secured. We're doing what naloxone was supposed to be doing for us. And we need to do the supportive care. So instead, let's treat us a pain. Let's sedate him. And I mean, the guy was out, like hardcore out, because of the other stuff that was in his system, but still giving a little bit of opiate there, hoping that maybe we'll bring the blood pressure down a little bit and the heart rate down a little bit to help with some of that acute withdrawal that he's probably going through. And I think that's very important to think about when you're getting this patient who is an overdose and you decide to give them naloxone. If you're noticing the heart rate and the blood pressure go up significantly, it probably is not going to help you out to give another dose in most cases, because you're probably actually making the situation worse, and it's going to just cause us more headache down the line when we're trying to take care of this patient's acute withdrawal.
Across the nation, most people have switched to giving naloxone intranasally. And I think that since we made that switch to intranasal, in my own opinion, based on what I've noticed, is that these patients are requiring higher doses. So they'll give 2 milligrams.
And I'm seeing the same thing. Yeah.
So I think it's just, I think all it boils down to is the variable absorption through the intranasal route and the lack of patience on our part, because it may take up to 8 or 10 minutes to see any response from the intranasal route, if at all. And I've had a lot of cases where I've given it intranasally, just so I wouldn't have to start an IV right away and start ventilating the patients. And someone else shows up on scene and they want me to repeat it just a few minutes after the initial dose. And I think that might be one of the reasons that we're seeing higher doses with the intranasal route is, one, it's got the absorption's variable, and people don't wait long enough to see if the patient responds to it.
And I think it's very important what you said there about the intranasal delivery and waiting longer, because it is going to take longer for the absorption in most cases, because assuming it even gets absorbed right, because part of this also relies on you giving appropriate delivery. And after watching a few police videos where they're administering naloxone, they're not doing it the right way in most cases. And I think a really big part of that, this is not to knock our law enforcement colleagues, but I think the real big reason why this is happening is because of just lack of training and refresher training on this. Because some of these videos, you're watching them, they're shaking like a leaf as they're trying to put this together. They're trying to read the directions as someone's acutely overdosed, and then they just squirt it all over the place, basically. So that's why I said a lot of times what we'll do is, if it was given intranasally or was not given IV and they did not already give up to 4 milligrams, we may be doing more. And that's not because we're magically thinking our magic naloxone is going to work better than your magic naloxone. The reason is because maybe it didn't get absorbed very well, because if you're got this supine patient where you squirt all 2 mLs of your naloxone into one nostril, that's what police did ahead of time, then yeah, probably most of it didn't get absorbed. And then maybe EMS got the IV and may or may not have given naloxone via IV. That's going to partly determine our decision. But pretty much as long as I can say that there's been at least 2 milligrams of naloxone that's been given IV, then I'm probably not going to do any more in most cases, unless there's maybe something really worth trying. Maybe they had a partial response and they're back in it because in their 30-minute drive to the hospital, they started to have depression again, because you have to keep in mind with a lot of these opiates now, maybe there's some concern. I know there's a lot of debate on this, but maybe there's some concern that with these longer lasting opiates that they may actually have some complications as a result, where they may need repeat doses or maybe a naloxone drip or something along those lines.
And I get the feeling for the toxicology literature that that's fairly rare and exclusive to some pretty gnarly agents. But there's not really a whole lot to expound upon.
Yeah, and with my patients that I've been seeing, I really haven't noticed that. I've worked in several different centers, and each one has slightly different populations, but they all balance out the same way. They all are people who end up needing, a dose or 2 of naloxone pre-hospitally. And by the time they come here, they're totally fine. And we may sit on them an hour, maybe 2 tops, because maybe we're working on other stuff with them. They're all fine and dandy. They want to get the hell out of here. They want to go home. And so we usually don't sit on them for very long, because a lot of times they're okay. Unless there was something else that caused you to maybe do a little more of a workup, you usually don't have to do anything with these patients. And yeah, the whole naloxone drip or repeat doses is rather uncommon. And yeah, I would say it's rare. I think maybe, I've maybe done that a couple of times. I've never had to do a naloxone drip. I've maybe had to rebolus it once. And that was because it was given pre-hospital and it was so acute of an intoxication.
Just a cursory look, I think clonidine overdoses in kids required quite a bit of Narcan to elicit a clinical effect. But usually they're getting supportive care anyway. So it's kind of one of those things that's 6 of one, half dozen of the other, at least to me. Because if you have a BVM and if you have good airway adjuncts, then and oxygen, you've essentially solved the problem of the overdose. The life threat is managed. So what does Narcan do but make our lives easier? So that's just my take on it. Because from my point of view, in the very acute field setting, if you have a good airway, if you're ventilating and you're oxygenating appropriately, the emergency is effectively over. So all Narcan does is help us out, and maybe, if dosed right, help the patient out to just maintain their own respiratory drive.
Nope, I completely agree. I think that's basically the entire argument with naloxone in a nutshell.
And the other thing I want to touch on about iron naloxone was that the number one mistake I see in its administration, other than giving it to an apneic patient, is that it's not actually atomized. So we use the MAD device here, and oftentimes I see people push it really slowly. And in the MAD device, you actually have to give it kind of a hard push for it to properly atomize through the device. And even then, let's see, I can't remember the authors, but we'll put them in the show notes. There was a intranasal naloxone study, and it showed that it only had about a 4% bioavailability. So compared to your IV or even your IM groups, your bioavailability of IN Narcan is probably not going to be optimal.
Yeah, and I've noticed that a lot too, where unfortunately, and it's hard without being there in person to see what's happening as far as why it doesn't get delivered that well. But I've noticed a lot more issues with the intranasal delivery system in general. It's not a bad idea, especially for law enforcement, because I'm not expecting law enforcement to start an IV or anything like that. But as far as actually with these acute, overdoses and stuff like that, and how to manage it, I really think that doing the quick intranasal is worth the try at least, but understand there's a lot of limitations with it.
And going back to what we were talking about, patients requiring repeat doses of naloxone, I've had quite a few patients wake up after naloxone administration and refuse transport. And what I've seen a lot of people do is say that you're not allowed to refuse, or they enlist the assistance of police to kind of coerce or force them to go to the hospital. I don't think that we should tell people that they have to go, that they're required to go, or if they don't go, they'll go to jail, unless that's true. But when I have some patients refuse after naloxone, I generally always try to make it an informed refusal, and I consider that high risk. So what I'll do is I'll contact medical control and see if I can get some orders to give IM naloxone before they go their own way, just to help to prevent them from going back unresponsive, if that's a thing, which I think it's probably is a thing, like you said, depending on the route and stuff of their ingestion.
I think there's a wide variety in the literature that says this may be a thing, it may not be a thing, but it's probably not that big of a deal. We talked about like the lipid solubility of different opioids and stuff like that, which could definitely be of concern. But some of the data that initially supported the EMS field refusal of the opiate intoxicated patient, or the opioid intoxicated patient rather, was based on data that was before this whole spate of adulterated agents. So what they were dealing with was like registries from California where it was more traditional heroin overdoses, more and less of the fentanyl analogs or fentanyl benzo splits and stuff like that. Now, from what I gather from the toxicology world is that it's still pretty safe to just watch these folks for a little bit, even in the ER, maybe 2-3 hours, and then discharge them home, even if they did ingest a synthetic opioid. Chip, is that kind of the case in your ER, or is that different?
Yeah, so in pretty much every ED I work at, like I said, you're probably keeping these people for about an hour or two after they check in. Because realistically, from the time from pre-hospital, because of how far most of these patients are out and stuff like that, they're going to be a couple hours out from their overdose. So it most likely is going to be okay. And really a lot of these patients where you're going to, at least in my experience, where you're going to see these repeat doses being needed, it's going to be pretty obvious, and it's usually going to be pretty obvious early on. I know it's not the best comparison ever, but let's talk about anaphylaxis for a second. Biphasic reactions are incredibly rare, and I feel like the same thing happens with opiate overdoses, that it's incredibly rare to have this kind of, for lack of better words, almost a biphasic reaction. So does that mean we need to keep everyone for hours or days? Hell no. We can probably send them home with the understanding, because most of these people aren't going to want to stay for several hours anyway. So just like you said, in the pre-hospital setting, the same thing happens in the ED. They come in because they were forced to, because it's either go to jail or go to the hospital kind of situation, or whatever, case happens. I'm sure it happens in Kentucky the same way it happens in Missouri, is that go to jail or go to the hospital. But, long story short, these people are coming in and then they automatically want to leave. And so usually we can talk them into like, hey, let's just take a second. You don't have a ride out of here anyway. Like, while you're in here, let's just give you some fluids. We'll just watch you for a little bit. We'll see how things go. And you just kind of talk them through everything and make them feel like, things are being done. But all you're doing is kind of sitting them on them just a little bit longer until their ride gets there. And you make sure that they have someone safe to watch over them, just like you would with any other type of intoxicated patient, and make sure that the informed decision-making is there. I think that's the biggest thing, is anytime anyone's wanting to leave AMA against medical advice, that it's very important that we have shared decision-making. We have a very informed decision-making, that they have that capacity still. Which realistically, most of these patients, once you take away their high because you've reversed their effects, they're going to be pretty cognizant and they're going to be able to answer stuff. And so I do a quick neurological exam with them, make sure there's no significant trauma going on or anything like that. And usually that's going to be enough. So for me, at least, a lot of these patients are going to be going home, and they're going to be going home rather quickly. I'm not going to keep them unless there's something that specifically I have concerns with.
I think something that we should probably screen for a little more routinely, both for evaluating reasons why a patient wouldn't respond to naloxone, plus to kind of help evaluate them cognitively after they wake up, is entitled CO2. Because I think there was a pretty cool case study. It was one of the Chicago ones, wasn't it, Ryan?
No, it was actually from Manitoba, Canada.
Canada. Yeah, so someone overdosed on carfentanil, and they actually never really got the patient. They never really were able to reverse it with naloxone. They ended up put the patient on a ventilator, and he woke up a few days later. But the reason for this was because the PCO2 was 138. So I think it's good to monitor waveform capnography and CO2 anytime we pick up a BVM. I think it's something that we should just start doing and adapt that to our practice. And it would help clue us in on why a patient's not waking up after naloxone, or why they're still a little confused after they wake up. And I think that might contribute to a few of the reasons why they might be a little combative after they wake up, because they're still a little hypercarbic.
I like how you say a little when it's 138. That's a shit ton hypercarbic.
Just a smidge.
But yeah,
I COPDers here in Kentucky. That's probably not normal.
So I love when I get people and their CO2 is like 90, almost 100, and I'm like, how the hell are you still talking to me? I'm like, that's some pretty significant COPD or shit like that going on. But yeah, I completely understand. I'd agree with that. Is that there's going to be a lot of, basically it comes down to, there's going to be a lot of alternative issues going on. And so some people just get so focused on the fact that, they overdose on an opiate, that's what we have to deal with, but not realizing the bigger picture. And so again, it goes back to the basics, almost if I can kind of summarize in some ways here. So basic PPE for us, nitrile gloves, maybe a mask if you really are worried about aerosolized stuff, which is most of the time not an issue. Then you're going to give them some naloxone. You can do it intranasally. Just make sure you're using an atomizer and that you're actually pushing it the right way to make it work, and that the patient's appropriate for that. Get your IV. If you need to give more, great. If not, no big deal. If they're doing better, awesome. But if that's not working, then you need to consider other issues going on. I really like the idea of talking about end-tidal CO2, because that's something you can do pre-hospital. It's not like you got an ABG that you can pull up and check it out. Although end-tidal CO2 is usually going to get all the information you need that my ABG is going to show me in the hospital setting. So you get that. That's going to just be one more little clue there. But realistically, if they're still not able to protect their airway, you intubate them. And after that, you're making sure they're oxygenating and everything. You've pretty much done what you can do in the pre-hospital setting for these patients. And now it's just supportive care.
I absolutely agree with that.
Sorry, I think I did your summary for you.
No, that's
awesome.
That's fine. That's a good summary, better than I could do.
You're good.
Okay.
Was there anything else you guys wanted to talk about? Going back through the questions here. Did we talk on air about the patient? Yeah, about how some people they feel like they're lightheaded and stuff like. Yeah, we talked about that on the air. I'm pretty sure.
Yeah, the psychosomatic or the psychogenic response to.
Yeah,
I think there's
because that's the number one
video
that drives me nuts.
The video that there was a law enforcement body cam video and thought he'd been exposed to carfentanil, and it was meth.
It was meth.
They even said it was meth.
Yeah, they said it. The poor lady is like, it's ice. What kind of fentanyl is that? Well, it's meth, actually. So, actually, do you think maybe we should wrap up on that little thing? Like just ask if I have anything else? Because that one really annoys me for a couple of different reasons. Because if someone automatically responds as far as as soon as you squirt naloxone up their nose, it was not a fucking opiate overdose.
If they can gag on naloxone, they probably didn't need it to begin naloxone. With. Yeah.
I think you even put that in a Facebook post, just phrased just like that too.
Yeah, if you don't need a BVM, you don't need naloxone. That's a pretty good rule of thumb.
Yeah, and I think that's the big thing is, did they need any sort of respiratory support? No, they didn't need naloxone. Whether or not it was actually an opiate, did they need any sort of respiratory support? No, they don't need naloxone.
I've actually had a case where we had a guy laying under a vehicle at a bar. We show up on scene. Everything seemed like just your typical overdose, heroin overdose. We start ventilating with a BVM, give some Narcan. We wait, 5 or 6 minutes. No response on the waveform capnography or anything. And I noticed his heart rate was kind of low. It was super low, in the 50s. I'm like, well, this doesn't make any sense. I gave Narcan. We're ventilating him. Something's wrong. Then I looked at the pupils, and they were obviously unequal, and one was fixed and dilated. Oops. And then I'm like, okay, we need to go to a trauma center. And then I'm like, did anyone see what happened? Can someone come over here and tell us what happened to him? And I told the cops, I'm like, this guy has a major head injury, and we need to know how he got it. So then they started investigating and realized, oh, yeah, he was just in a fight, and someone hit him, and he fell and hit his head on the pavement.
You actually bring up something really quick here that I would add to that, and that is to look at the pupils early on any of these types of ultra-mental status patients. And what I tend to do is when you bring a patient into my ED, if I'm around, I'm actually going to usually be at the head of the bed, because either it's going to be just me or maybe there may be a second person here, but I'm usually going to do the airway. So it's really whoever's going to do the airway. But when you're at the head of the bed, as soon as that patient's transferred over and everyone's getting set up so you can do the airway, just take a quick look at the mouth, the pupils. I look at the ears too, because I want to see, is there a hemotympanum going on as well? But all I'm looking for are major signs of trauma, but I'm looking at the pupils because are they fixed and dilated? Are they reactive? Are they unequal? All those types of things are going to help tell me the clinical picture of what's going on here. And there have been a couple of times where I looked and opened up and no one's looked at it beforehand. I see a blown pupil, and yeah, we're going to take care of this, but your actual first trip is going to be to the CT scanner real quick so we can see how significant this is and then plan from there. And I think that's something that we have to look at really early on, is just before you go and put that airway in. Whether it's pre-hospital or in the hospital, take a look at the ears, eyes, nose, throat, mouth, and you may find some stuff that you weren't expecting.
Yeah, I think we're becoming so cynical around overdoses that we're not doing a good assessment, and it's going to cause us to really miss a lot of important stuff.
Yeah, and unfortunately, I've seen that a couple of times.
That bias, confounded by some diagnostic anchoring, is a really dangerous water to start treading in.
Well, Chip, thank you so much for coming on our show.
I've loved this. This has been a great conversation. It's going to be a long one, so hopefully everyone sticks with it. But no, I've really enjoyed this.
Hey guys, thanks for listening to Curbside Bedside. We want to especially thank Chip Lang with Total EM for coming on and sharing his expertise. We hope that you'll check out his podcast. You can also find him on Twitter at @the_total_EM. He truly is an awesome person, and he's very personable, and I'm sure he would love to answer any questions you might have. This is Floyd with Curbside Bedside. Bye.